Today's program, I've taken too much time already. We have a tremendous lineup for next year as well, but tonight is going to be fantastic. I'm going to introduce Greg Serrao, who's put together a monograph on a very difficult topic, part of it made more difficult by Dr. Leon having a paper on the similar subject just a few weeks ago in Dr. Fuster's journal. So Greg is trying to outdo Dr. Leon, which is going to be difficult.
So thank you, Dr. Goldman. Thank you, Dr. Fuster, and a special thank you to Dr. Leon. We really enjoyed having you here today with us, and we appreciate you taking the time to do this. So today's topic is severe asymptomatic aortic stenosis, and I just want to take a few minutes to review the literature in regards to this topic. So aortic stenosis, as you all know, is a progressively debilitating disease that eventually mandates the need for surgical therapy. The most problematic issue in managing those with severe aortic stenosis is the risk of sudden cardiac death. The risk is estimated at 1 to 1.5% per year in the asymptomatic patient, and up to 3% over just 3 to 6 months once symptoms develop. This highlights the need to optimally manage those with severe aortic stenosis regardless of symptoms. There's no proven medical therapies to alter the course of aortic stenosis. Studies have looked at the use of statins, ACE inhibitors, angiotensin receptor blockers, and bisphosphonates, but none have shown a proven benefit. Surgical correction of the valve is the only treatment that has been proven to decrease mortality. There's a clear consensus that when symptoms are present or the left ventricular ejection fraction is depressed, that surgical therapy is warranted. However, the optimal timing of intervention for those who are asymptomatic is unclear and controversial. This has several problems associated with it, including first, that there is a risk of sudden cardiac death despite being asymptomatic. Second, late symptom reporting may result in irreversible myocardial damage. And third, the operative risk increases with patient age and in the development of LV dysfunction. As a result, many investigators have looked for ways to identify those who are at highest risk despite lacking symptoms. Several high-risk features have been identified through the use of echocardiography: a peak velocity of greater than 5 meters per second, a rate of progression of peak velocity by more than 0.3 meters per second per year, and a left ventricular mass greater than 110% of what is predicted by age and height. Each of these have been incorporated into the current guidelines and suggestions for when surgical therapy should be sought after despite lacking symptoms. Exercise testing is another very important tool with these patients for two reasons. First is an objective way to see if symptoms are present, which might be missed by the practitioner or the patient. And second, it can measure exercise capacity and the hemodynamic response to that exercise. Current guidelines recommend intervention if either of these are abnormal. Stress echo also offers insight into those who may benefit from early intervention. European guidelines currently recommend surgery for those who have an increase in mean gradient by more than 20 millimeters of mercury with exercise. CT and MRI may also be helpful by quantifying the amount of aortic calcification present, quantifying myocardial fibrosis, and better estimating the valve area, but have the least data associated with making decisions in the asymptomatic patient. Serum BNP may also be helpful, both when measured at rest and with exercise. European guidelines currently suggest early intervention in those who have an elevated BNP without an alternative explanation. To date, there have only been a few studies which have examined the role of early intervention in aortic stenosis. The first study was in 1990, which looked at a group of 143 patients, and they found no difference with outcomes with early intervention versus watchful waiting, and is the basis for this common strategy. However, several recent trials have reached different conclusions. One study in 2010 looked at a group of 197 patients, 95 of whom received aortic valve replacement without symptoms. They found a significant decrease in cardiac mortality at 6 years. The most robust study came in 2015, when 1,808 patients who were asymptomatic were studied, and 291 had aortic valve replacement. They found a lower incidence of all-cause death and heart failure hospitalizations at 5 years. A recent meta-analysis, actually by Dr. Leon and his group, combined all data available to date, and they estimated a total 3.5-fold higher risk of all-cause death with a watchful waiting strategy when compared with AVR. The best data on managing this subset of patients will come from a planned AVATAR trial, which is aortic valve replacement versus conservative treatment in asymptomatic severe aortic stenosis, which is currently enrolling. It should be noted that there is currently no data nor any planned trials to study the role of transcatheter aortic valve replacement in those who are asymptomatic, though it sounds like one is being planned at Columbia. As the safety of TAVR improves and the indications widen to a low-risk patient population, this will be important to consider. In sum, asymptomatic severe aortic stenosis is a difficult but important clinical problem which needs more investigation to develop an optimal approach. Thank you.
Thanks very much, Greg. An excellent summary on a fascinating topic. Well, anyway, it's my task to introduce today Dr. Marty Leon, and I will say from the beginning that every year or two he comes out with a paper that really makes everybody to change their ideas about things, and recently it has not been different with TAVR and with a recent paper in asymptomatic aortic stenosis. So he's a real contributor, and he has done this over many, many years. So let me go back and say a few things about Dr. Leon. Actually, he was born in New York, and actually he had his MD degree at Yale, and then he spent 2 years there, actually more than 2 years. He did 3 years on internship and residency. And then he moved to NIH, this was in 1978, to spend 2 years there as a clinical associate. He went back to Yale in 1980, and then he finished his fellowship in cardiology. Now, he then decided in 1983, the place to work at that time was NIH, and certainly he got into the NHLBI as a senior investigator. And then he was the director of the cardiovascular lab of the cardiac catheterization laboratory. Between 1990 and 1999, he was director of cardiovascular research at the Washington Cardiology Center. Now, he then subsequently spent a few years, I think 5 years at Lenox Hill, and since 2004, he has been at Columbia Presbyterian, and he's the director of the cardiac catheterization laboratory. Now, every place he has been, he got a significant award or honor, outstanding alumnus. This was at Yale, Andreas Grunsik Career Achievement Award, Concepts in Contemporary Cardiology Award, the Solasi 2003 Career Achievement Award, AHA Achievement in Cardiovascular Society and Medicine Award, etc., etc. Now, one of his main contributions, certainly to the field, was he's the founder and chairman in 1990 of the Cardiovascular Research Foundation, the CRF. We all know about CRF, and I have understood and never understood the success of being able to put the whole interventional enterprise and not interventional with the TCT in the United States. That is one of the most impressive things I have ever seen, how he was able to do that. Well, I could go on, but just to mention, he has close to 1,000 papers. And it's interesting, he has papers of the highest impact factor journals. And in fact, I think he started with the New England Journal of Medicine in 1979. And his first paper, interestingly, was about the diagnosis of thalassemia. And then he is one of the first who used verapamil in patients with coronary artery disease, in patients with angina. But it's fascinating to see how well he has done over the years. And I'm sure you will be able to contribute every year or two on something that shakes us up altogether. Thanks very much for visiting us today. Martin, I will give you a plaque to remember your visit here. And this is the faculty and fellows. As you know, this is a plaque for outstanding expertise and teaching at the Anandi Sharma Visiting Professor Simon Duck Memorial Lecture, June the 20th. Sure. With the plaque, sure. And I kept the check. Put this together here. You don't lose it, okay? And then you can sit here in the middle, okay? Well, I'm going to call Dr. Dangas, who's going to moderate the discussion, and then the many experts here. Dr. Kinney, Dr. Korth, Sengupta, Alan Stewart, and certainly Greg. Okay?
And yourself?
Having vacation today.
Okay.
Hey, man.
How are you? You wait for the rest of the crowd. I'm sure there are enough chairs. You can.
Plenty of chairs.
You move a little bit this way. Partho next to Dr. Leon. Yeah, very well. Well, there was a fascinating talk in the at the lunchtime conference, and there's a great review by Greg right before regarding this very interesting topic. And TAVR in general is something that shakes up general and interventional cardiology the past few years. I have a very simple question to start with. We're talking about a symptomatic disease, and symptomatic disease, as indicated now, what's the difference may be? I'd like to first ask Partho, that's why I ask you to middle in the center. A lot of it that we do these days before we do the TAV is based on echo. Actually, the guidelines and the reimbursement is based 100% on echo criteria. So what's the diagnostic certainty that we have with this criteria from your point of view, and how this may be echo-based limitation when we move to perhaps an asymptomatic population that you're, as an echocardiographer, your discipline has to be, or your certainty has to be bigger. How do you feel about that?
So if I understand the question is, what is the certainty that a certain hemodynamic criteria once defined on echo is able to categorize a patient? Well, the point of symptom or asymptom is a clinical diagnosis. I think there's nothing to do with echo at that point. Echo defines a certain hemodynamic and anatomic criteria for defining severity of the aortic stenosis. So there are two aspects. So the symptom is a clinical question-based assessment, and the hemodynamic and the aortic valve for the severity is the second part of it when it's put together. Now, with regards to defining the severe aortic stenosis, I think we have seen an evolution over a period of time. We've seen basically flow becoming a criteria in the assessment of aortic stenosis. So you have now 4 categories of severe aortic stenosis that can exist based upon low flow, normal flow, and the presence of gradient, which is a low gradient or preserved or a high gradient. So there's a 4 category, but I completely agree that although the guidelines presume that there is a certainty, absolute certainty about being able to categorize patients in the 4 groups, sometimes we do come across a situation where cardiac catheterization may be required because there may be ambiguity at an echocardiography level. So now that percentage is very, I don't think it's, I would probably say about 5 to 10% just on the top of my head, where we do see a difficulty of completely being able to categorizing patients just based upon aortic stenosis, and you may need to have a little bit more important solutions from cardiac catheterization needed.
Yeah, Marty, do you think from your invasive point of view, this category of discrepancies may actually be amplified in a minimally symptomatic or asymptomatic population?
No, I don't really think so. In the fact, when I was learning about valvular heart disease at the NIH, we didn't really have echocardiography. All we had was invasive. I mean, that was the era when, it was after the era that Gene Braunwald was doing transbronchial punctures of the left atrium to measure pressures in the left heart. So in the beginning, it was all invasive. I think once we got good at echocardiography, frankly, the invasive diagnosis has become less relevant. There are occasional patients where the echo window is just so difficult, either transthoracic or transesophageal, where I think you can augment the echo imaging with some invasive hemodynamics, but I think that they're few and far between. In fact, it's a class 3 recommendation to cross the aortic valve to diagnose aortic stenosis if you have a good echocardiogram. So I think there's pretty good confidence in your ability to discern the significance of AS, but the point I wanted to make is these discrete categories bother me. This is a disease process. Disease processes are associated with a continuum, and to make some of the arbitrary cutoffs that we do between mild, moderate, and severe based upon either peak velocity or mean gradient or indexed valve area are probably not the way to look at this. I think you've got to look at the totality of what you're seeing, which is the impact of the disease on the ventricle. So you look at LVH, you look at left ventricular function. Many people now are looking at longitudinal myocardial strain as being another parameter. You can assess the magnitude of calcification by CT quantitatively. I mean, there are many things that you look at, and I think it's the totality of that picture that gives people the confidence that they can differentiate patients who have different degrees of severity of AS. So I wouldn't focus solely on the echocardiogram.
Great. And an aspect that many of us may have heard using or have used already in patients with minimally symptomatic might be the stress test. Greg, from your reading and your review, I know it's at round sometimes in the unit we say, okay, well, what did they stress the patient to figure out this and that? What did you find regarding the stress test as a strict endpoint? How has it been used?
So I think stress testing is really important, like I mentioned in my review, because it can objectively tell you if symptoms are present. And actually, in Dr. Leon's study, he made a point to mention that up to 50% of people who were stressed and thought to be asymptomatic are actually symptomatic. So I think it's really important to do. And there's a class 1 recommendation that if clear valvular symptoms are elicited during a stress test, that the valve should be replaced. And it's a 2A if there's a decreased exercise tolerance or an abnormal blood pressure response. I think the problem with stress testing is that short of those criteria, it's not clear exactly what to do with the stress test. And in my review at the end, there's a table that talks about all the different studies that have looked at stress testing and the criteria that they use on what to call positive. And things like ST depressions, ST elevations, or even the development of VT, it's just very unclear what to do with those patients. So I think that's where the problems come in.
So it sounds like a little bit easier said than done. If there are symptoms, it's helpful. If it's not, and we have to use the surrogates, other different studies have used different definitions. Did we read that, Mari? This very useful table with all the definitions you can find the last page of the review was actually from your paper. Were you surprised how many different definitions were actually out there when you put them
yes,
together?
I was very surprised. First, I really have to give credit to Philippe Généreux, who was the first author of that meta-analysis. He really did a wonderful job, and he was very meticulous in looking at every manuscript that used the stress test to try to help diagnose or differentiate patients with aortic stenosis. You know, I'd like to take it back just one step. I've learned that as you get older, you become more of a medical historian, in part because you've lived through many different eras. And when I went to the NIH, as Valentin mentioned, 1978, that was sort of as being the halcyon days. It was right after Braunwald had left and Sonnenblick had left, and so many important things were accomplished at the NIH. But you remember that probably the most quoted figure in all of cardiology is the Ross Braunwald depiction of what happens in patients with aortic stenosis over time with respect to latency, symptoms, and then ultimate clinical outcomes. But if you read that manuscript, and it's not so easy to read, it's not even so easy to get anymore, it's 1968 in circulation, first authored by Ross, it was based on, we didn't have echo. And we didn't have caths either, really. This was based upon a post hoc necropsy autopsy series, originally 12 patients. Average age of death was 63. They all had either rheumatic or bicuspid aortic valve disease. They supplemented that with some additional autopsy data, but the conclusions that were derived in retrospect were perhaps amplified based upon the level of evidence that was provided, both clinical follow-up and even autopsy evidence. So I have to say, Even though it's viewed as dogma and we worship at the altar of that one figure in terms of how we still treat patients with aortic stenosis, I mean, to me, those data and that study was anachronistic. I would dispute very aggressively a lot of the conclusions and say we have to have a complete revisit of how we think of valvular aortic stenosis in the modern era and not be bound by that, early observation. Clearly, we recapitulated the importance of not treating aortic stenosis in the PARTNER 1B trial, where we randomized patients who had severe aortic stenosis to current therapy, and 50% died in the first year. So if you have a symptomatic patient and you don't treat it, then they will do poorly. But the definition of asymptomatic and the outcomes of asymptomatic versus symptomatic, I think, really have been poorly defined and deserve a complete reevaluation in the modern era, knowing that in this country alone, there are 600,000 patients with severe asymptomatic aortic stenosis.
These are good points. Alan, let's take us a little bit in the OR. When you operated in certain cases, is there a portion of those, maybe the bicuspid specifically, or some other portion that you wish you had operated earlier from a technical point of view? Is there something during the case that poses a challenge to you?
Not particularly. The degree of calcification makes it a little bit more difficult to cut the valve out, but the disease process is pretty much limited to the leaflets and the annulus, and from a technical point of view, the severity doesn't change. However, with severe LVH, these suicide ventricles, if you will, that we operate on, it's very, very difficult to manage them post-operatively. The technical aspects of doing an AVR really are not dramatically different, but their care is a little bit more difficult, coming on and off bypass, and with dramatic changes in pressure in the first couple of hours post-op. I think, I wish we could have operated on those folks a little sooner.
Interestingly enough, I noticed that there are some guidelines from Europe that indicate a little bit more clearly more categories of asymptomatic AS to have some form of treatment as a 2B guideline, the increasing of a BNP marker as an indicator of early CHF, the severe LVH, whereas in the US guidelines, only a peak velocity over 5 is recognized as a valid indication in asymptomatic patients right now. Marty, would you like any comment? Do you have any comment about how perhaps somewhat more forward the Europeans are here? Is that the general theme that US guidelines may be lagging a little bit behind this aspect already?
Well, I think the U.S. guidelines are in the process of being revised. In fact, there's going to be a focused update fairly shortly that hopefully will bring us a little bit closer to the modern era. I'm not sure, BNP is difficult. I think in the absence of anything else, a lot of the patients with AS also have mitral valve disease. Many of them have ischemic cardiomyopathies. They have other reasons. They have atrial fibrillation. They have other reasons why the BNP may be elevated. So the BNP, I think, is important to follow serially, but an absolute cutoff may be problematic. Certainly, I think LVH is a problem. I think by waiting in somebody with severe so-called asymptomatic AS, several things can happen that are not good for the patient. One is they do develop worsening LVH. They do develop varying degrees of LV systolic dysfunction. And by the way, an EF of 50 or 55% in an AS patient is already abnormal. That's not normal anymore. Their baseline EF should be 65%. And they also develop atrial fibrillation. And many times, it was very interesting in the PARTNER trials that 40% of the patients had atrial fibrillation who came to us for therapy. And clearly, in an AS patient who presents an atrial fibrillation, they do poorly. It was an independent predictor of one-year mortality, just the fact that they had baseline atrial fibrillation. So waiting for these things to happen as a patient declares magically that they have the first onset of symptoms, I think does put the patient at risk, not to mention the concern or potential risk of sudden death. And sudden death, although it's not frequent in asymptomatic patients, maybe 1 to 2%, in that range, or 1 to 1.5%, but 75% of the time, it's the first manifestation of disease, and there's no way of anticipating it or obviously dealing with it. So those are many of the reasons why we think that this watchful waiting strategy is a wishful thinking strategy, and that we need to be more aggressive about identifying patients that have severe AS where the effect on the ventricle and the effect on other things that ultimately can affect prognosis may already be seen, so that the trigger point for intervening should be readjusted.
Yeah, and Jacob, let me get the chance to ask you about AFib. You do AFib ablation all the time. Do you see that a chance that when the valve disease is not as terminal, if you want, or as advanced, even if some AFib happens, you may get a chance to correct it by ablation, or do you think that the AFib with any valve disease, it may be very difficult for you to treat?
And if the burden of AF far exceeds the severity of the valvular disease, then it's likely in the younger patient that this is pulmonary vein mediated. But the moment you start seeing AFib, once the valve disease has progressed, then non-pulmonary vein factors come in, which significantly reduce the impact of a PV-based AF ablation strategy. So yes, if there is AF with significant valvular heart disease, outcomes are usually poorer.
Jason, let's touch a basis of another aspect. Is a thing that also happens as the disease progresses is that the access gets worse. Is that a consideration? That should be a consideration, because you know that the easier the access, the better the outcome of repairing. Would that be worth waiting from your point of view?
I mean, I think it's a very interesting question, and I think from my perspective and my observation is that the access is, I mean, it associates with worse outcomes. If you can't do transfemoral access, the patients have worse outcomes. But I think that's as much a marker of patients with more advanced disease. People with PVD, as you know, have renal dysfunction, other comorbidities. So I think it's a marker of disease, as well as a slight increase in the risk at the time of the procedure. But I think, you know, if there's to be any consideration of, you know, a trial using TAVR for intervening on asymptomatic AS, I think the starting point would be people that were amenable to transfemoral access, because doing transapical or transaortic access for a patient that was asymptomatic is a fairly morbid type of procedure that we try to steer away from very aggressively and stick to the transfemorals if at all possible.
Now, and aside from access, Dr. Kinney may want to give us a comment regarding, from your point of view, giving you a possible case for an asymptomatic AS for a TAVR. Is something that might click, that might be a not such a good case, or might be perfect case for an early repair of this patient with TAVR if it was available? Is there such a thing as like something that you see early on that make your procedure simpler or less complicated, I would say, in such patients?
I think after listening to this lunchtime talk of Dr. Leon and understanding that how, you know, asymptomatic AS should be treated like you just mentioned, rather than, you know, wait and watch for symptoms to appear. That's one. Other thing also, I think we all claim that the patient is asymptomatic. I don't believe that truly it's asymptomatic. If you then start asking the patient exactly what has been happening, if you go deep down to the history, everybody has symptoms. What happens, they change their lifestyle and then tell us that we are asymptomatic. So I believe as, you know, technology is improving and the valve size are becoming smaller and smaller, TAVR probably would be safer to be done earlier on, like you mentioned.
Great.
I think, George, this issue with access is important, because if you can't do percutaneous transfemoral, you might as well do open surgery for most of these patients, to be honest, unless they have so many comorbidities that open surgery is going to be an issue, because we haven't seen any benefit with transapical or direct aortic versus open aortic valve replacement. I really believe strongly that the difference with percutaneous transfemoral is substantial, so much so that when we're doing this low-risk study now, we're only doing it in patients that we can do transfemoral. I don't want to compete with surgery if we have to do transapical, because I think, you know, it's not going to be better. In fact, it may not even be as good.
No, I would completely agree. The one question I had in your low-risk trial for TAVR that you're planning, have any concern about the durability, or is there an age cutoff of which the patients will need to be enrolled?
It's a great question. I wake up in a cold sweat most nights, but many of those nights it's worrying about this issue with durability, because it's the one fatal flaw that can make a difference. I began to feel more comfortable, you know, after we had very good echo control data, yearly echo data with the core lab, for 5 years, but as you well know, many surgical valves do fine for 5 years and then fail between 5 and 10. So we don't have good 10-year data. There was some early data presented at PCR that I think was perhaps exaggerated in terms of confusing the process of structural valve deterioration with the clinical expression of that, which is the need for reintervention. And I think that's been somewhat resolved, but I worry. These are bioprosthetic valves, and I think the durability issue is going to be an important one. An advantage is that even if it's not as durable as the best surgical valves, and frankly, the only two that I think have ever been proven to be truly durable beyond 10 years is the Hancock 2 and the Perimount. All the others have not really, by that standard, have been proven to be durable. Even if they're not quite as durable, I think that the opportunity to be able to do valve-in-valve in most of these patients is very real, and it's a not very difficult procedure. So I think that may offset things a bit, but we need more data, which begs your question, should we be treating young people with this? But we don't have long-term durability data. In the low-risk study, we don't have an age cutoff. We initially had an age cutoff at 65. We took that out. But we aren't treating bicuspid valves. So that's excluded, and that's segregated and partitioned into a registry that we'll learn more about. Because we really need to learn how these patients behave, irrespective of age. And the presumption is that most of the non-bicuspids are going to certainly be in their 70s. So I think that we'll be okay. But this is going to be a large issue that will take another 5 years, at least, to resolve, to have enough normal risk patients that live for 10 years to really assess durability based upon the clinical definition and the echo assessments of valve degeneration. I would also hasten to add that right now the assessment of transcatheter versus surgical valves in terms of the approval process and how we look at durability seems to be a little bit imbalanced. I mean, right now, you know what it takes to get a surgical valve approved. It's 800 patient years with 300 patients maybe for a year, and based upon an OPC, which is decades old and doesn't involve, things like death or stroke as part of the OPC. So right now, it's easier to get a surgical valve approved than a transcatheter valve. And these valves, the surgical valves, are not looked at with serial echoes the way we're looking at these valves. So I think it's going to be important to establish some parity in terms of how we look at bioprosthetic valves in order to see if there really is a difference relative to surgery.
Yeah, another aspect, actually, we're talking about durability of the valves, etc. Another aspect is a leaflet issue that actually was an awakening for the surgical valve community as well, because there was, I suppose, for so many years of doing those valves and implanting those valves, it was interesting that, again, this wasn't studied as well, and this now uncovers the issue of more systematic angiography pharmacotherapy, etc., that is applicable for all of bioprosthetic valves. It may ultimately not only impact the immediate stroke risk or TIA risk, may be very low, but perhaps the durability issue. Alan, you want to comment about that, how early thrombus might end up damaging the valve later on, perhaps?
Well, that was the big issue for us when we first started doing TAVRs at Columbia years ago, was that it was inconceivable to us as surgeons that you could actually crimp a leaflet, because we had this belief that we'd never touch the pericardium of a surgical valve, because it would lead to some sort of microfracture and perhaps early thrombus generation. And this no-touch technique, I think we convinced ourselves that we would never have leaflet thickening, frozen leaflets, thrombus on surgical valves, but we never really looked at it. We never really came to any agreement as surgeons as to how to treat bioprosthetic valves in the short term with anticoagulation. And so when we got involved with TAVR, so Jesus, there's no way this is going to work. It's going to clot. It's going to calcify early. It's going to tear. And surprisingly, we're learning that, and that's led us in the surgical community to have sutureless valves now that are surgically implanted, a similar type of structure with nitinol that I think what you'll see over the course of time are sutured valves going away. Each company has surgically implanted sutureless valves that are being used in younger patients, and they're being rapidly adopted for shorter cross-clamp times for concomitant procedures. And I think that as we evolve with TAVR, so are we evolving with our understanding of biological valves. I think that many in the surgical community have eliminated using any sort of mechanical valve in the aortic position. I don't think I've implanted one in the aortic position in years. But I think we're evolving as a group into better therapies.
You know, George, it's kind of interesting. I learn a lot more from my surgical colleagues now who really understand valvular heart disease than some of my medical colleagues who really follow the patient but don't understand valvular heart disease sometimes as well. But I was listening to a lecture from Alain Carpentier, it's about a year ago, and he was giving a talk about the history of surgical bioprostheses. And in his original thesis, he talked about a process of acquired hemocompatibility, which is to say that when you put in a glutaraldehyde fixed valve in a human being, they have an adaptive process. And that adaptive process includes edema and early thrombus formation that occurs in almost everyone. So I was amazed, because this is just at the time that we began to find this leaflet thickening, and he's telling me that leaflet thickening is part of the adaptive healing accommodating process of putting in a glute-fixed valve in a human. So I found that interesting. We are now exhaustively studying this issue of valve leaflet thickening / thrombosis. And there are now 6 studies and over 2,000 patients that are going to be studied and analyzed using 4D CT, high-resolution, time-resolved CT studies to look at this process. And ultimately, I think we'll understand more about the incidence and whether or not it's associated with clinical complications. I'm guessing not, but we'll see. But I think more importantly, we have a random pharmacotherapy process in how we manage these patients. It is very, very random. It's almost chaotic. When we took a poll of 300 high-volume TAVI centers around the world, no one could agree on anything. What drugs, how long, what doses, which patients. So I think we do need better pharmacology studies. And I don't for a moment discount the fact that there may be many patients that would do better with short-term anticoagulation, as these valves adapt over the first 3 to 6 months. And it's something we should revisit, I think, much more seriously. It's the one major gap, I think, in the whole evidence space that we need to continue to work on.
So when someone talks about the symptomatic disease, 3 things that come first to my mind. The symptomatic disease may be perhaps associated to maybe a little bit not a severe AS, perhaps. Are we talking about maybe a moderately severe AS in some concealed ways here or not? Or perhaps we have these dilemmas very often, low gradient AF, we say low gradient, low flow, but the echocardiographer looks at it and says, oh, it's very severe. But again, this is triggered by a clinical complaint. Partho, you have these discussions another time when there is a dilemma, you adjudicate, so to speak, these cases. If now we pose these valves in a symptomatic patient, would you be able to more comfortably or as comfortably adjudicate severe AS in a low gradient kind of situation there, or we would be holding off such cases perhaps?
Well, I think, again, the knowledge is evolving, and we have, as was correctly pointed out, that aortic stenosis becomes more of a syndrome, and all the associations and diabetes, hypertension, renal disease, and it adds to the complexity. And as a consequence of the complexity, you see some of the patients are required to be, you need to redefine and understand, is it exactly the valve leaflets are not opening, or is it the flow which is not, you need to assess that situation, and sometimes you need to employ simply beyond just a simple echocardiogram, some more tests to be able to delineate that difference. So I think this particular way of looking at flow and the valve and the interaction of the flow and the valve and how much it opens the peripheral load, this complexity is going to continue, and I think you're going to continue to see this engagement of dialogue between the non-invasive laboratory and the treating physician. That clinically, I think this patient doesn't seem to be in severe aortic stenosis, but you're calling this as a severe aortic stenosis. What is it? I cannot hear the murmur. But then I think this continuous team-based approach of defining the severity of aortic stenosis is perhaps the biggest evolution of collaboration that we have seen after the TAVR. And I don't foresee this being so clear-cutly decided by one lab or by a physician. So I think this team-based approach is going to continue. So there's no simple one-step solution to it.
Maybe we need serial echoes, perhaps, to adjudicate some of those. Jason, another form of an early disease, perhaps, we find some patients with a little borderline aorta, ascending aorta, someone with a bicuspid or something like that, and say, you know what, we may consider a TAVI for asymptomatic, but how about if this aorta dilates a little bit later? How do you view this other type of association?
I mean, so you're really getting to the pathobiology of the disease and what's the relationship between bicuspid valve and aortopathy, and when do we intervene on both? And it's always a discussion we have if someone needs aortic valve intervention and they have a dilated aorta. We always, I think, revisit the question, are they a surgical candidate, and should they have both diseases fixed at the same time rather than just doing TAVR and only addressing the aortic valve? But I think there's don't get me started on the basic biology of aortic stenosis, I'll be here all night, but there's been a lot of studies suggesting this is an atherosclerotic-like process, but it's not really atherosclerosis, or it's not exactly the same. And I think there's a lot of data coming out now to show that there's fibrotic components in aortic stenosis which are mediated by endothelial cells and endothelial cells switching to become fibroblast-like cells, which occurs in athero, but is probably more prominent in AS. So I think there are some differences in the biology which may account for the relationship with aortic pathology as well. But I think that these are individualised cases that need to be addressed individually as to whether they can be operated or not operated, and if we're comfortable just doing the aortic valve or leaving the aorta alone.
Yeah, I know when we talk about the treating asymptomatic patients, we want to say perhaps that you want to predictably avoid perhaps, or try to avoid the post-dilation, not to touch the valve too much, have to avoid the pacemaker. How predictable are those goals? Although I would say from a clinical trial point of view, I think we'd like to say that if you go to an asymptomatic population, you have to make those things as predictable as possible and avoid them. Is that something that you see from your everyday practice and the way we practice, that that might be able to come in a room and say, you know what, I will be able to avoid the X and Y and Z, or there's a certain leeway that we kind of have to play during the procedure most of the time? And how do you see that changing, perhaps?
I think currently, since the population that we are dealing with have, bad aortic disease, significant calcium, the way the annular size, everything is there, it's difficult to predict. But if we are going for a low intermediate risk and probably low risk, that's the time we may be able to predict exactly what you say, like we have our interventional strategies of how we deal with coronary artery disease, that we may be able to predict that how we can do this case way faster than what we are able to do right now.
And Jacob, any input from your point of view regarding risks for pacemaker? From practical point of view, that could be a bigger negative, one could say, if a patient is symptomatic, doing TAVI, end up with the pacemaker.
I mean, besides what you already know about procedural techniques of making sure you don't implant it very deep and so on and so forth, I think it would be important that the risk of pacemaker doesn't take away from the benefits that you accrue by entering a patient population that's asymptomatic. But more importantly, from my perspective, most of these patients probably won't have a low ejection fraction. So the exact implications of pacing in the long term are probably going to be related to how frequently they are paced, and it would be important to keep in mind that many of these patients in follow-up aren't pacing and that the EP appropriately readjusts the pacemaker so that they don't get exposed to long-term pacing.
You know, George, it's interesting when we talk about how radical it is to suggest that we would intervene in patients with asymptomatic severe AS. When you look at the only really good prospective follow-up study, which is Lancelotti's study, not that many patients, about 150, that had normal EF, so which is good, that had stress tests, so they truly were asymptomatic, at least by those stress test criteria. In the asymptomatic patients, 50% had cardiac events in 2 years. So what are we saving here? So maybe you're saving a year, maybe you're saving 2 years. As long as the benchmarks for a fully percutaneous transcatheter procedure are respected, and you've got good data that say that your mortality is less than 1%, your stroke rate's less than 1%, you can get the valve in with an expected pacemaker rate of 10% or less, PVL is now down to the low single digits, you don't have catastrophic complications like root rupture or coronary occlusion. If you've been able to show that in a similar population, then again, I don't see the rationale for waiting in these patients. We're not, even though we call it asymptomatic, we operate on asymptomatic AR patients. We operate in patients with degenerative mitral valve disease who don't have symptoms or have very mild symptoms. So I think that, this is not such a radical concept, yet it involves, if you were to add the asymptomatic patient group to the AS population, you're talking about hundreds of thousands of additional patients every year. It's that large a demographic group.
Yeah, indeed it is. And another flavor that I get when I think about asymptomatic, I also get a little difficulty to perhaps decipher multi-valve disease in this population. If there is MR, patients, not many symptoms. If there is some TR, there's pulmonary hypertension. How do we decipher those? Or we have a little bit of a difficulty in approaching, I would say, multi-moderate valve disease. Perhaps aorta is a little bit more, and we give priority to that, or maybe someone else can say maybe it's not, and we have to give priority to another valve. How do we navigate this concomitant disease aspects as well? Obviously, they're not going to be part of any trial here, those cases.
Yes, but I would argue a lot of the concomitant diseases are acquired diseases secondary to waiting too long to manage the aortic stenosis. Most of the MR is functional, and 2/3 of the functional MR after you operate on the aortic valve goes away. It's not degenerative MR. So it's secondary MR. The pulmonary hypertension is clearly due to the LVH and due to the aortic stenosis for the most part. The right heart failure is always functional and due to left-sided disease, which is why, again, I'm suggesting that this obsession with waiting to the point of patients declaring themselves, and we're usually now talking about patients that are in their 80s. And I defy your ability to really discern clearly symptom status in patients over the age of 80, other than in a relatively small percentage. They have too many other comorbidities, orthopedic considerations, really to be able to understand, what level of symptom burden they carry.
Well, Alan, from your point of view, is in a similar situation, if you're operating and there's an AS and you have other diseases, how lenient are you? How strict are you in stitching up or putting some rings here and there in the other valves? Is that something, is a major concern, a small concern? You try to bypass it?
It's somewhat of a small concern. I agree with Marty that we're tolerant of 2 to 3 plus MR during an AVR and think that that's going to get better. I don't have the same conservative opinion on the tricuspid, though. Yes, it's due to waiting too long, I agree, but we will normally throw a ring on a tricuspid because I don't see that the tricuspid gets better, at least as quickly as the mitral, and it makes it much more difficult to manage them postoperatively. So it takes 10, 15 minutes to put a tricuspid ring on. So if we have 2 to 3 plus TR or a dilated annulus bigger than 40, we'll put a tricuspid ring. But I generally leave the mitral alone because it, like you say, it's by and large functional, and it will resolve over the course of a couple of months.
But I have to applaud Alan. He's unusual as a surgeon in doing what he's doing. In that, I agree. I think tricuspid disease, when it gets to the point of being severe with a dilated annulus above 40, the Dreyfus criteria, those patients do poorly. So I agree that those patients should be ringed. But most surgeons are not doing that. I mean, we're seeing, we've been looking at this, and it's uncommon for people to do a tricuspid annuloplasty, even when they have severe TR, which is not uncommon with aortic stenosis. We've gotten, as the aortic valve has become interesting to us, we've also started to think about how we can better manage some of the other valves, particularly the right and left-sided AV valves. But the tricuspid is really a mystery to us. But I think that we have underestimated the importance of severe TR, and we've treated it generally too late. So I think that that's really a progressive approach to do what Alan's doing.
Well, an inherent advantage of the percutaneous approach and TAVI is that you don't have to make all this decision at once. Alan has to make it exactly during the surgery. You can start with a TAVI if you have this approach and get a stepwise approach and see if they still need some other intervention later on. I think it's about time that we conclude our main discussion and maybe invite any of the faculty or students or fellows or to offer any questions. And there's a microphone, or perhaps just by your voice. Roxana.
So, Dr. Leon, thank you so much for coming and enlightening us today. Today you gave us an amazing lecture about where we've been and where we're going in the field of TAVR, TAVR. And last week during our symposium, Alan was in the cath lab during a case. That's right. And we talked about expanding indications from the highest risk, and I really have to applaud you for putting together your strategy of bringing this technology to life, because you went to the niche population and inoperable, and you're moving the needle in the opposite direction rather than the other way around. And last week, you, Alan, said the way we're looking at it is who's not a candidate for TAVR. So I would love to hear, who are you referring to surgical aortic valve replacement?
Well,
today and maybe 5 years from now.
I think the so-called brilliant strategy of doing these serial clinical trials, it perhaps wasn't so brilliant. We didn't really have a choice. Our surgeons would have killed us, and the FDA wouldn't have allowed us to do it any other way. And I applaud them for imposing the rigor that was necessary to have a cohort risk-based strategy to try to see if this new technology can work. And to a certain extent, it saved us, because it gave us about a decade to mature the technology and the procedure. Because if we had tried to do low-risk patients in the beginning, it would have been a disaster. Oh, yeah. So now we have better devices. We can do things. In our lab, more than 95% of the patients have cutaneous transfemoral. So it really has helped us to be able to do this strategy. So who would we not do it in? I mean, certainly I think that there are specific anatomic situations where I would not do it in. Depending upon the magnitude of the calcification, particularly as it extends below the annulus and into the LV outflow tract, those are very, very difficult patients to treat, where you can predict you're going to get significant paravalvular leak. They're not so easy to treat surgically, but they've got a better chance of getting a better result. So that certainly is one cohort. There are other patients that have small annuluses that those patients may do better with a root enlargement. They may or may not. We still have to see. There are certainly some patients that have a very large annulus that we don't have valves that are well suited. There are bicuspids that have aortopathy that we shouldn't be treating. There are concomitant diseases such as complex coronary disease that should be treated with, and that's such a common association. In our study, 60 to 70% of the patients have coronary disease. And 30% have had previous CABG. So they're going to be patients with complex coronary disease that would be better suited to the combined strategy of AVR CABG versus what we can do with PCR and TAVR. There are certain kinds of aortas there are horizontal aortas that are problematic, and there's vascular access issues where we can't easily use a transfemoral approach that might do better with open surgery. I will say that we're getting creative with this vascular access business. So I've seen people doing carotid, subclavian axillary, suprasternal, transcaval. So we're finding a lot of interesting ways to stay out of the chest and still get the device to the heart.
Plus carotid?
Yeah, plus carotid, of course. So it's there are some patients that are going to always be best suited for surgery. And I welcome the fact that we have such great surgeons who can manage these patients. But I do think in the future, after we get through this next round of studies, it is likely that the majority of patients would be good candidates for TAVR, and I think they should have an opportunity to have a percutaneous transfemoral procedure.
Dr. Fuster.
Really, the question is that who is not going to have aortic valve replacement, or who is not going to have TAVR, and you have few people left that will not have TAVR. What is going to be the training? What is going to happen?
I'll say that at Columbia we had a far more organized, integrated cardiac surgical program that involved a significant period of time spent learning wire skills. I think that any cardiac surgeon who is training today or is less than 10 years out in practice, if they have no wire skill ability or no collaboration, they're going to find it difficult to earn a living in the very near future. So I encourage all of the residents that I have to at least spend a year with someone afterwards, and I think that might be too minimal. The cardiac surgeon of the future is going to spend at least a third of their training period in a lab, or else they're going to be antiquated.
Marty, have any comments?
Well, you know, it's interesting. Right now in the United States, if you look at the mean number of aortic valve replacements, sole AVRs, not AVR CABG, done by a cardiac surgeon, the average number, the number is 8 per year right now. So right now there are a lot of low-volume AVR surgeons, believe it or not. I agree completely with Alan. We've had a training program for about 9 years at Columbia where we bring surgeons into the cath lab and train them as interventionalists. They spend 4 days a week for a year in the cath lab. It's amazing. It's almost scary how good the surgeons are because their hand-eye coordination, their ability, you know, the visuals, they're so much better than the interventionalists. It doesn't take very long to train them. It's a little scary. I had predicted about 5 years ago that in the future that about 20 to 25% of the interventionalists, forgetting about what you call them, surgeons or from the cardiology side, should be surgeons. And I'm still hoping that we can convince our surgical training programs to have that approach. I will tell you, if I had to retrain again right now, and you'll think that this is a little crazy, I would want to be a cardiac surgeon. Because if I'm a cardiac surgeon who has interventional skills, I can do anything. It really makes you an extraordinarily powerful person and gives you tremendous perspective on what's best for the patient without having to really depend upon your own skill level in terms of making that decision.
Anu, would you like to accept a surgeon in for a 6 months into the program?
I'm going to pick
And then make sure you don't treat them any differently than the regular fellows.
I'm going to pass that question.
One of our fellows may say something now.
Thank
Natural follow.
Great discussion, Dr. Leon. What is the role of valvular arterial impedance on these asymptomatic aortic stenosis?
Yeah, there's a whole, it's a very interesting area of valvular arterial impedance. I mean, these are patients that again have a low flow state generally, and we have a way of describing that. We calculate Z-scores. It gets very, hemodynamically rigorous. We had Philippe Pibero give us a lecture last week on the 50 shades of gray of aortic stenosis, where we went through all of the different complexities. I mean, obviously, when we look at what happens across the valve that affects flow, you're looking not only at the forward output, but you're also looking at the resistance, and depending upon the blood pressure, that resistance can change and can affect forward output, and can influence the low flow state. Low flow, low gradient AS, true AS, is a terrible disease. Those patients medically do awful. It's the worst category of patients. They do better with surgery, but still don't do great with surgery. And we're not sure if they do better better with TAVR than surgery. They probably do at least as well. But that's a difficult disease state. And there's from a ventricular standpoint and a valvular impedance standpoint, these patients generally do not do well.
Dr. Goldman.
Just two aspects, I guess, for Dr. Leon mostly. What's the impact on the asymptomatic patient, do you think, long-term, of the neurocognitive impact of those microemboli? You showed a great slide of a patient, of a series of CT scans in patients with a protective device versus unprotected. And whose brain would you prefer? You gave us that question, which was important as you look at the asymptomatic group and as you go forward, what the impact neurocognitive skill set will be. And also, what happens with the paravalvular aortic regurg long-term and its impact and its mechanism?
I think one of the strengths that we've had in trying to develop the TAVR program is that we've been intensely self-critical. Nobody's been more critical about the complications than we have. When we saw strokes, we reported them and we figured out ways to be able to reduce the severity. Similarly with PDL. So I'll start with PDL. The next range of valves, PDL is going to be non-existent. It's going to be very much like what a surgical valve is. We have found that if you have moderate or severe PDL, that certainly it is independently associated with reduced mortality. But right now the PDL rates at a year with the SAPIEN 3 are 1.5%. They're extremely low. So I think with the next round of technology, we're not going to see PDL as an important issue. So I'm not as concerned about that. Neurocognitive function, if you do neuroimaging and you're looking for perfusion deficits by diffusion-weighted MRI, you will see them in the vast majority of patients after TAVR. You will also see them in 50% of the patients after surgical AVR, and the size of the lesions are twice as large with the AVR than with TAVR. So you can pick your poison. Generally, these patients don't present as clinical strokes. The clear relationship with neurocognitive function has not been well established yet, but we're in the midst of doing that in a clinical trial that I'm pretty excited about, that we'll have some evidence to draw upon over the next few months. But I want to keep emphasizing, whether you do or don't operate on a severe asymptomatic patient, you're only saving yourself a year or two. And in that year, a lot of things can happen. Patient can develop atrial fibrillation and have a frank stroke. Patient can develop LV dysfunction that doesn't recover. Patient can have multiple comorbidities that intervene that make any operation more significant. They develop LV systolic dysfunction and heart failure. So it's not as radical a concept to say to operate on severe asymptomatic AS, because you're only delaying the inevitable, and potentially you're allowing the patient to avoid some of the complications of aortic stenosis that make future management more difficult. But in a few months, I'll give you some good answers about the relationship of neurocognitive function to perfusion abnormalities associated with TAVR, because we've got a 350 patient study that we're going to be looking at.
Can I ask you a question, Dr. Leon? As we talk about, potentially doing TAVR in severe AS asymptomatic patients, and you alluded to it before, but can I draw you out on what do you think your approach would be to the person with the small annulus that potentially would take one of the smallest valves, and for the audience that usually leaves the patient with some residual gradient, 10 to 20 millimeters of mercury, and also the issue of then if the valve does fall apart and we had to go back in and try potential valve in valve, then obviously that's really not a good situation, because then you have a very severe gradient if you had a valve in valve in one of the smaller stuff. So would your threshold for intervening if we're taking a TAVR on someone with a very small annulus be higher, assuming this is a high-risk, non-surgically operable patient?
It's a great question, and I wish I had a perfect answer. I think some valves in the future will be better suited for small annuluses. That certainly is something that we are concerned about. We generally don't leave them with very much of a gradient, but there's no question that the valve area is much smaller. So the valve area, if you put a 20 millimeter SAPIEN 3 in, the valve area is going to be 1.2. That's what it's going to be. And if you don't do a root enlargement, the same thing is going to happen with surgery when you treat these patients with small annuluses. Unfortunately, many of them tend to be women, and it really probably helps to explain some of the gender differences. Will it impact my thinking about how to manage the asymptomatic patient, again, you're looking for situations where you might find that TAVR or surgery are going to be, less helpful, and maybe it'll tilt me a little bit towards waiting in a patient like that, who truly has a small annulus. It is striking. I was shocked, Alan, how difficult it is to get surgeons to do root enlargements in aortic stenosis.
Yes, it's somewhat of a lost art, to be honest, especially with some of these smaller, again, the Magna E's, which are the next generation of PeriMale. People think, well, I'll get one size bigger, so I won't have to do a root enlargement. Well, it's really just kidding yourself. And the number of surgeons that put 19 millimeter valves in people is shocking. I think that's really setting them up for a later almost impossibility of having a great result with a valve-in-valve TAVR. So I won't ever put a 19 in anyone, and if they need such a small valve, but just a root enlargement is something that people aren't trained in anymore. You don't see it by those that are teaching residents. So the next generation of residents didn't learn how to do it.
It was interesting. I had a conversation with Michael Mack, and we were talking about the younger patients. We're still worried about durability of all these valves. And I said, well, in younger patients, we probably should be, favoring surgery. And he said, absolutely not. He said, I'd put a TAVR in. Patients can be 40, 50. And then when that fails, I'll put a second one in. And then when that fails, I'll do my first surgery. And then when that fails, I'll do a valve-in-valve and a surgical valve.
I think it's a cute statement. It's not exactly an AVR to take out a TAVR. It's a real operation to get it out, especially the evolute or the core valve, because its attachment is a little bit more robust than, say, a sapien, where we can, by and large, just put our fingers on it and pull it. Where the evolute attaches down in the mitral curtain can potentially involve a substantial rebuild of the heart in order to take it out properly once it's endothelialized and then do an AVR. So I think that while that's a nice thought, I think we're a little away from it.
Dr. Barman.
It was a great discussion, everybody. I was curious. It seems obvious to us all, that it's kind of inevitable that the patient group eligible for this technology is expanding and potentially expanding rapidly. Can you just give your thoughts on how you foresee this being applied across the country, in terms of not just at centers of excellence? You commented on SAVR, surgeons with SAVR volumes in the single digits. Are you concerned about how this technology is going to be applied at across the country, not just at academic institutions?
Yeah, I'm always concerned. We trained 40% of the sites that do TAVR in the U.S. We trained at Columbia, because we were doing training courses every other week. It's risen rapidly in the U.S. As of 2015, there were 344 sites in the U.S. that did TAVR. That number will slowly increase to close to 500, which is about 25% of the number of sites in the country that do PCI. And it's going to plateau, and if I had my druthers, it would plateau and stop. I don't think we need more sites than that from the standpoint of U.S. demographics. You need about a site per million or per 750,000 population to properly service the community. Anything beyond that is only medical politics and medical economics. It's not better health care. So I think that it doesn't have to be an academic center of excellence, but I think that there should be practicing centers that know how to do valvular heart disease, both surgery and intervention, and that those numbers should remain fairly flat. So far, that's been pretty much mandated by the FDA and by CMS, and the companies have bought onto it. I hope that it continues.
I'd like to thank Dr. Leon, visiting professor for the day, and the great panel that contributed to this discussion.